Hello, this is Elena Coucher. I will be presenting to you the high-risk newborn. This is over Chapter 25. It will be addressing acquired, congenital, gestational, and age-related problems. We're going to be talking about the preemie baby. We're going to be talking about those that may be born large for gestational age, maybe their IUGR. We're going to talk about neonatal infections and mom drug use with the neonate. The infant at risk, these are conditions or circumstances superimposed on normal course of events associated with birth and adjustment to the extrauterine life. This could be birth trauma, any maternal substance abuse, infection, and congenital anomalies. Additionally, the high-risk newborn can be classified by birth weight, gestational age, or the predominant pathophysiologic problem, or according to mortality. Infants born, for example, to mothers with diabetes are at greater risk of developing respiratory distress syndrome, as well as being a large baby suffering from birth trauma, perinatal asphyxia, hypoglycemia, cardiomyopathy, and hyperbilirubinemia. Birth injuries or any injury sustained during labor and birth, they may be unavoidable, but sometimes they're not. Ultrasound allows antepartum diagnosis of any macrosomia, hydrocephalus, or unusual presentations. Elective cesarean birth may be chosen for some pregnancies to prevent any significant birth injury. Infants who are born macrosomatic over 4,000 grams are at high risk of hypoglycemic episodes. As well as any birth injuries. We have to watch these babies very, very carefully. A small percentage of significant birth injuries are the unavoidable ones, in spite of all the skilled and competent obstetric care they might receive. And this may be related to difficult or prolonged labor or abnormal presentation. Some injuries can be cannot be anticipated until the circumstances are encountered during the childbirth itself. So now let's talk about nursing care management for these babies that encounter birth injuries. Some of the injuries that can happen: a skull and clavicle injury from traumatic birth, maybe it's a big baby. There can be some peripheral nervous system injuries that occur as a result of forces that alter the normal position and relationship of arm, shoulder, neck. And I think even in the normal newborn assessment, the video that I showed you, there were some aspects of it that talked to you about looking at symmetry of the face, which is what we're going to deal with when we're looking at neurologic injuries. About 70% of neonatal skull fractures are linear because the newborn skull is flexible. It takes considerable force to fracture it. But if it does happen, there are two types. There's a linear or there's a depressed. Location of the fracture and involvement of any of the underlying structures can determine its significance. If a clavicle is broken or fractured during delivery, it usually doesn't require any special treatment to repair. Erb's palsy, and this is a PNS system injury. But it's damage to the upper plexus. It usually results from stretching or the pulling away of the shoulder from the head, and it occurs when you have shoulder dystocia or a difficult breech or vertex birth. A plexus injury, though, should recover within 3 to 6 months. If it's not completed by 3 to 6 months, usually it's because there's an avulsion of the nerves that results in some permanent damage to that baby. Nursing care of the infant when we're talking about those with facial paralysis. Now, if we're looking at that symmetry of the face when we're doing a newborn assessment, does their mouth open the same way on both sides? Is there asymmetry or symmetrical? We may have to do gavage feeding. We do encourage that moms still breastfeed, but gavage feeding may be initiated to prevent aspiration. preterm infant is determined if a baby is born at or before 37 weeks gestation, regardless of their birth weight. Some of the associated causative factors for it: gestational hypertension, maternal infection, multifetal pregnancy, HELP syndrome, premature dilation of the cervix, placental or umbilical cord conditions. Cause is completely unknown at this point in time. There's no definition as to why a woman will have a preterm infant. All we know is what can cause it. Sometimes there is just nothing there, and a woman's water will rupture, and she's having a preterm baby. It is highest among low socioeconomic groups, and it can be related to a placental problem, such as previa abruption. The preterm infant, of course, is at risk. Their organs aren't mature. Systems are immature, and they lack that adequate physiologic reserve to function in that extrauterine environment. It is responsible, the preterm delivery, for 2 out of 3 infant deaths. Prognosis and severity of complications are related to the level of maturity. Earlier an infant is born, the greater chance of complications. At this point in time, the earliest stage of viability is around 23 weeks. And I've seen them in the NICU at 23 weeks. Major complications from it: respiratory distress syndrome, difficulty regulating their body temp, infection, and hemorrhage. As preterm infants, they're challenging. It is to take care of. It's challenging to maintain their respiratory status. It's very challenging to regulate that temp. They don't have really good fat stores. Remember, we talked about brown fat and how that in fetal development, we had a discussion about how brown fat develops within that last month of pregnancy. And so they have this bump up of fat that they live off, and they're like, it's like an insulator, I guess is what I'm trying to call it. So if they're born at 23 weeks, that insulator has not developed yet. What you're going to find with a preterm infant, assessment-wise, you're going to see a low birth weight baby. You're going to see minimal subcutaneous fat. They're going to have a proportionally large head, wrinkled features, thin, smooth, shiny skin, lanugo, sparse, fine hair on the head, inactivity, absent or weak reflexes, minimal creases on the soles and palms. They're going to have prominent eyes, a soft, pliable ear cartilage. The males are going to present with few scrotal rugae and undistended testes. The female, they're going to have a prominent labia and clitoris. They're just physiologically immature, period. They exhibit periodic breathing due to the pliable thorax, immature lung tissue, and immature regulatory center. So care of the high-risk newborn and family, protection from infection, we want to use standard precautions with them. It is also noteworthy that not all hospitals have an NICU, so not all hospitals can provide that detailed, in-depth care for their neonates, and so they might have to transfer them. We have to be concerned with their hydration, and we have to worry about their nutrition and when to start breastfeeding or providing nipple feeding of some sort, or gavage feeding. The late preterm infant is any infant born between 34 and 37 weeks. They're still at risk. They still have problems that they're at risk for. These babies are often termed their near-term deliveries, and that's because they're not really quite, physiologically mature enough to be a part of the term nursery, but yet they're not sick enough to actually go to preterm nursery. So what Baptist has is a near term, and many facilities use that terminology, near term. 70% of preterm, it accounts for 70% of the preterm infant population. Late preterm babies and large for gestational babies are at risk for episodes of hypoglycemia. They're also going to be at risk for hyperbilirubinemia, sepsis, and alterations in the respiratory function, feeding problems, and thermoregulation. So let's talk about our preterm or our near-term babies and what we can expect with some of them. They're unable to produce adequate surfactant, so reduced lung compliance, the ability to fill with air. So it results in some ineffective exchange of the O2 and CO2. They have incomplete development of muscular coat of the pulmonary blood vessels, so they don't restrict in response to the decreased O2 levels. It leads to the left to right shunting through the ductus arteriosus, and then that increases the blood flow back into the lungs. The patent ductus arteriosus, it results in some pulmonary congestion for these babies, so then they get increased respiratory effort and CO2 retention. What do we want to assess on them? Well, let's look at their heart rate and rhythm and blood pressure. Also, be alert to what their color looks like, their perfusion and their pulses. O2 sats and acid-base status is also assessed. We want to monitor for any signs of hypovolemia. Nurses, we have to be prepared to intervene if the baby shows signs of cardiovascular issues. Do your assessments and do them well. We might have to utilize some internal and external monitoring. This can be done with the arterial or venous catheters, and it'll be through the umbilical arterial catheter or the umbilical venous catheter. So some early signs of respiratory distress, and we did talk about some respiratory distress in the normal newborn. So we know that if we're seeing a baby with some nasal flaring or grunting or tachypnea, then we're becoming a little bit on the concern side. Increasing respiratory effort will then show some retractions. They're going to have apnea that lasts greater than 20 seconds, and they're going to have some central cyanosis. We need to know what that pulse ox is, and we probably need to get some O2 on that baby. So what about putting O2 on them? What are the goals for that? We want to provide adequate O2 to the tissue. There's several ways that we can deliver that. We have to assess O2 needs with the pulse ox and ABGs as required. We just need to go slap O2 on them willy-nilly. Vital signs, we want to make sure that they have adequate respiratory function and circulation for perfusion. We're now using 21% O2 to begin resuscitation. Rather than 100% due to the possible neurological issues that we've encountered over the years. O2 sats anywhere between 93 to 95% is acceptable. We may have to deliver the O2 via the oxygen hood or a nasal cannula. It needs to be warmed and it needs to be humidified. For assisted ventilation for respiratory distress, I'm not going to go over vent settings with y'all in the sense of, I'm going to test you over that. However, one thing that I want you to take from talking about vent support is you always do your assessments. You always do. Just because they're on the vent does not mean that you do not listen to them, that you don't evaluate what their heart sounds are, what their lung sounds are, anything. Or what their skin color is. You need to watch all these things, and don't watch the monitor. The monitor is not what we watch. This is not just something to take from the high-risk infant. This is something to take with you throughout critical care. As nurses, we sometimes become very dependent on the monitor, but we need to be more dependent on our eyes and our ears than what that monitor says. Ventilators are usually set up and monitored by the respiratory therapist. The nurse can make and will make adjustments to it as ordered. We have to look at pulse ox on them when they're on the vent. We have to look at parameter orders. Don't just assume they're ventilated so there's no need to assess them. Listen to those lung sounds. Make sure the endotracheal tube is patent. If they're still unable to maintain the parameters, even after you might increase the O2, you've done everything, respiratory's come in and done everything, then we're going to have to call the doc. there might be something more that we have to do for them. Surfactant is very important for the lungs. It's like what do you want to call it? Like the gel that helps it to move. It's not the gel. It's when you think about frying an egg in a skillet, you want to make sure that you got enough oil in there or butter or spray that it just, after you fried that egg, it'll just slide right on out of the skillet. Think about that as for surfactant. It's administered usually as adjunct to oxygen and vent therapy. It improves respiratory compliance until the infant can generate their own surfactant. And it's usually given to infants less than 32 weeks. It can be given through the ET tube. Without surfactant, the alveoli don't stay open, and high pressures are needed to open them with each breath so the baby doesn't get tired. So it acts like a detergent. It reduces that surface tension of fluids that line the alveoli and respiratory passages. It results in some uniform expansion and maintenance. So again, I always think of it as my egg sliding out of the pan. I want to be able to move my pan up and have my egg slide down and slide onto my plate. I don't want it to meet any resistance and get stuck at any point in time in the pan. All else fails and our babies are not doing good, we might have to look at nitrous oxide and ECMO. ECMO is the extracorporeal membrane oxygenation. The blood gets shunted from the heart to a pump that oxygenates it and then returns it to the systemic circulation. What it really does is it allows the lungs to rest. It's contraindicated for greater than 34 weeks because of the anticoagulant therapy required, and they are at risk of intraventricular hemorrhage. Now let's talk about thermoregulation, because in normal newborn, I told you that thermoregulation is very, 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 very vital. These babies have limited heat production related to the decreased availability of glycogen in their liver and decreased amount of brown fat. Those are two important components of regulation. They have also decreased muscle mass and muscle activity, so they're unable to shiver. Factors that increase the heat loss: they have increased ratio of body surface to body weight and decreased subcutaneous fat for insulation. Blood vessels are also closer to the skin surface. And they have that thin, really permeable skin. Extension of the extremities also, they're not in that flex position that we want to see newborns in. So they are laying there with extension. They're flaccid. They're not able to maintain that temp by keeping everything close to the core. A decreased ability to vasoconstrict superficial blood vessels and conserve their heat. Infants who have a weight of less than 1,000 grams have a very narrow window of temperature extremes, very narrow. Very small infants may need the environmental temp to equal its skin and core temp, or it may be even higher. We don't want to make the baby hyperthermic, because that's going to make that baby have increased O2 needs, and they're going to burn through their calories. And when they burn through their calories, they're going to... So cold stress is also a component that we become very concerned about with our babies. What happens with it? They get hypoglycemic from the increased metabolism of the glucose. They become metabolically acidotic from the metabolizing of the brown fat, and they become hypoxic from the increased oxygen consumption. What happens when they become hypoxic? They need extra oxygen because they're cold in order to produce heat. So a cold infant with normal lungs will increase their respiratory rate in order to get extra O2. If the infant has diseased lungs, they may not be able to get enough O2 to maintain their brain and body functions. So there they go into respiratory distress, and they start grunting, retracting, having nasal flaring, and become tachypnic. We really don't like babies to get cold stress at all. They do not have to be severely cold stressed, though, to develop these problems. Some infants demonstrate these consequences if their temperature drops only 1 to 2 degrees. Cold stress. Assessment findings, you're going to see that baby looks pale. They're going to be mottled, cool to touch. They're going to have cyanosis, respiratory distress, irritability that's going to progress to lethargy. They're going to be hypotonia. They're going to have a weak cry or suck. They're going to become apneic and bradycardic. Maintaining that body temp, we want the neutral thermal environment to be 36.4 to 37.3. Radiant warmer or incubator is indicated for these babies. Rapid body temp changes can cause apnea or acidosis, so we only rewarm them at about 1 to 2 degrees per hour. When it's time to start weaning them from the incubator to the bassinet, we usually strip them down. We put them just in a diaper, shirt and cap, lower their temp in the isolate by about a half a degree every 2 hours, and we monitor them. Also, we have to look at their weight, feeding, and respiratory status when we start doing that. We might find that a baby is maintaining their temperature when we start decreasing the radiant warmer or the isolate, and we've got them at a neutral normal temp in there, where or it may be off and they're just still in the isolate waiting until they get moved to an open crib. And then we'll find that the first day they do get good, and then 24 hours later we're going in and checking their weight, and guess what? They've dropped, and that's because it's taking a lot of calorie energy to maintain that body temp, plus be able to nipple. So this may be a baby that has to stay in a warmer just a little bit longer. Neuromuscular function, bigger is better. These babies are susceptible to injury through damage to the immature intracranial structures during delivery, bleeding from their fragile capillaries, immature control of their vital functions, poor muscle tone, extension of their extremities, weak or absent suck, swallow, gag, or cough reflex. It's the most rapid period of brain growth and development is in the 3rd trimester. So neurologic function depends on gestational age, associated illness factors, predisposing factors like intrauterine asphyxia, and that which could have caused any kind of neurologic damage. So we have to carefully monitor them for any seizure activity, hyperirritability, CNS depression, elevated ICPs, and any posturing that could indicate that there's something neurologic going on with them. Renal function, they're unable to adequately excrete metabolites and drugs. They have concentrated urine. The maintenance, they're unable to, concentrate urine, and they're unable to maintain their acid-base fluid or electrolyte balance. We have to assess their INO and specific gravity. Those of you that have been to NICU, when you have a baby, how are we assessing their output? And for those of you that might not have been there yet, how we do that is we are weighing those diapers. We know we'll weigh a diaper, an empty diaper that has not been voided in or stooled in, and we will weigh it to find out how many ounces that it weighs, and then we'll add the baby's diaper on there to determine how much output that there was. Nutritionally, the goal is to prevent catabolism and excess fluid loss. Their difficulty in maintaining adequate nutrition because they might not be able to suck and swallow at this time. It's usually not coordinated until 32 to 34 weeks gestation. Gag reflex may not develop until 36 weeks gestation, so they can be prone to aspiration. They have a very small stomach capacity and immature digestive capacity as well. Breastfeeding is always encouraged. Oral feeding is preferred if an infant has adequate strength and GI function, but if they don't, gavage feeding using breast milk or formula through the naso or orogastric tube may be necessary. They may end up having to need some gastrostomy feedings as well. We allow for non-nutritive sucking because it improves oxygenation. It facilitates earlier transition to the nipple, and they become less restless and decreased energy expenditure. Each time that we take care of infants who are being gavage fed, it is important that we document the response to those feedings. We want to know whether the gavage or nipple was used. If gavage, then we need to know the size of the feeding tube, amount and quality of the residual if they had any from the previous feeding. And that's important. That's an important assessment tool there, because when we start seeing some residuals in infants that are preterm and they're maybe around the 15 to 30 day mark, we're starting to get thinking we might need to assess further and be aware that they are at risk for NEC. And we'll talk about NEC a little further on. Hydration, they're vulnerable to fluid depletion or overload and electrolyte imbalances. These babies receive supplemental parental fluids to give them extra calories, and many times electrolytes or water. Their extracellular water content is 90%, while only 70% in a term infant. They have very thin skin that doesn't create a very good barrier to water and heat loss. Are also vulnerable to fluid depletion, fluid volume overload, and electrolyte imbalances. We have to be aware of alterations in behavior, alertness, or activity level with them. It could be that there's something going on with their electrolytes. They could be hypo or hyperglycemic. They need highly humidified environments. Their fluid overload, if we're not monitoring their eyes and nose very well, and we're not looking at their fluid status very well, which I hope that we are. But fluid overload can result in some renal failure, CHF, or inappropriate, it can result in some pulmonary congestion and opening of a previously closed PDA. Hepatically, we're looking at an immature liver and difficulty eliminating bilirubin. They have increased risk of hyperbilirubinemia. They have decreased liver glycogen stores, so they're prone to hypoglycemia, and they have immature production of clotting factors, so they're at increased risk of bleeding. We've talked about hyperbilirubinemia with the normal newborn. I'm going to talk about it a little bit. I'm not going to go really far into it. Most babies end up with it in NICU. When they're in NICU, they end up under phototherapy because of the bilirubin. Early and frequent feedings do hasten the passage of meconium and excretion of the bilirubin, but if it's contraindicated, then we've got to get them under phototherapy to decrease that bilirubin. We usually send neonates cord blood to the lab to determine the infant's blood type and RH status. And if their RH status requires an NICU stay, then they may be staying with an exchange transfusion. May require to stay under the Billy lights, and you've got that on the previous slide, and we're going to always monitor the bilirubin levels. And what do we want to make sure? We make sure that their eyes are covered and we're assessing them and turning them. With hematologic function, they're predisposed to problems due to fragile capillaries, prolonged PT and PTT, tendency to bleed, decreased production of RBCs, large volume of fetal hemoglobin, loss of blood from test, and decreased survival rates of RBCs and decreased levels of circulating albumin. If they're going to bleed, they're going to bleed in their pulmonary system, GI tract, or any puncture sites. We have to continually assess these babies for anemia. We're looking at their pale skin, if they're apneic, lethargic, tachycardic, or if they have poor weight gain. And we usually in NICU at Baptist will do hematocrit every Sunday and Monday night. Infections. Listen, these babies might not present with infection like you or I would. We got to know what the maternal fetal history is for any risk factors. We need to assess any signs and symptoms of infection. They get passive immunity in the third trimester, but preterm infants have few antibodies at birth. We have to be extremely vigilant to keep the environment free of pathogens that can cause infection. We don't want to allow anybody to come into the NICU who's sick. What about delivering a preterm infant? Anybody who's delivered a preterm infant understands that there's some anticipatory grief. There's potential loss of the infant. You hope the infant will survive, but you prepare for the death. You have many ups and downs with micropreemies. One day you're up, the next day you're down. You have no idea what's going to go on. So they're going to have some grief. They can accept failure. They have to accept failure to give birth to a healthy full-term infant. There's also some developing attachment to the infant. It takes a little time. They're unable to hold some of the. If it's a micropreemie, they're not able to hold those babies like those that deliver term babies. Are maladaptive. They're going to have incidents of physical and emotional abuse that can be higher in those infants. They might withhold nutrition, do poor hygiene, bodily harm, emotional abuse as well, because they'll have lack of interest or true dislike of the infant. Some of the causative factors for it are financial burden, unmet expectation. Maybe the infant was a product of unwanted pregnancy or stressful relationship with a partner. Plus, some of these babies, they go home and they're just irritable babies. And so consequently, moms and dads get very overwhelmed. And I'm definitely not excusing abuse to an infant, but sometimes I think that can be a causative factor for it, is the irritability of the baby and unable to be able to satisfy its needs. The physical care environment, I'm just going to run through this. When IV access, blood work's going to be done, clustering care because we want to minimize the stim that we give them. Of course, assess, and they're going to be in an incubator, isolate, or a radiant warmer. Skin care, the skin is very immature, it's very permeable, so we have to be very careful and vigilant to what we put on these babies. Adhesives, oh my Lord, they can be bad for these babies with such thin skin. Think of an elderly person, if you've ever taken care of one, we've put silk tape on, and you pull that silk tape off of, and what does it do? They have that thin permeable skin as well, so it like rips the skin off. That's what happens with these babies. So we have to be very, very, very careful with them. Bathing, we do delayed first baths. When we do, you use a neutral agent, wear gloves. Try not to remove so much of the vernix. Let it stay on there. It's still a protective coat for the babies. We only do baths every Sunday and Wednesday nights in ICU. Now, that's just our policy. Other hospitals follow different policies. Your book states every 2 to 3 days. But daily, we're going to do some eye, oral, and diaper area care. We want to avoid adhesives. I've already said that. Because their thin skin is so thin, then they can have transepidermal water loss. So we keep humidity at 70 to 90%, and we do a semi-permeable transparent dressing when we have some micropreemies in there, and that means we put some saran wrap over them so that they do not lose any of their get any water loss. We want to prevent skin breakdown, decrease pressure from the mattress, dressings, and make sure their nutrition is adequate. Use any substances on the skin sparingly. Avoid heat lamps, which we don't use. Caution with warming devices. Fluid therapy, we got to be very conscientious when we're securing those lines. Environmentally, we have to be concerned about their auditory input and their vision. they have established night and day patterns and sleep periods. We protect their eyes from procedure lights. If we raise up the top of the isolette and we've got bright lights on, we want to protect their eyes so they're not overly stimulated. We also avoid decibels greater than 90. It's correlated with some intracranial hemorrhage, and also it can be some from ototoxic drugs like Lasix, Gent, and antimalarials. Complications of prematurity: respiratory distress syndrome, transient tachypnea of the neonate, patent ductus arteriosus, preventricular or intraventricular hemorrhage, neck, that's what we're going to talk about here real soon, apnea, a prematurity, retinopathy, and bronchopulmonary dysplasia is a chronic lung disease. Distress syndrome, the pathophysiology for it is lack of surfactant in the lungs that leads to atelectasis and labored breathing, respiratory acidosis and hypoxemia. Blood flow to the lungs decreases, causing the alveoli to become necrotic, and then the capillaries are damaged and the high membrane forms then. The infants that are most at risk for this are Caucasian males, babies born to maternal diabetics, second-born twins, C-section without labor, and third trimester bleeding. The initial assessment findings for RDS, they're going to have an increased respiratory rate, retractions. Their color may be satisfactory, and they're going to have some good air movement on auscultation. But it progresses to tachypnea, labored breathing, grunting, nasal flaring. They get more pronounced substernal retractions, find crackles, and cyanosis. What are we going to do to treat them? It's supportive. Best treatment is exogenous surfactant with adequate ventilation and oxygenation. It is a self-limiting disease, so respiratory symptoms will usually disappear after 72 hours, around the time that surfactant is produced in the infant's alveoli. We got to keep the acid-base balance. We got to monitor ABGs. It may be done via umbilical catheter or peripheral arterial line for all blood testing. We keep the neutral thermal environment. Infants who are hypoxic can't increase their metabolic rate when they are cold stress. Got to maintain fluid and nutrition, and monitor for complications from vent if it's indicated. Parenteral nutrition, because gavage and oral feedings during an acute stage can increase the respiratory rate and O2 consumption. What about transient tachypnea of the neonate? It's just a mild respiratory problem that begins after birth. It can resolve within 48 hours. It results from delayed absorption of fetal lung fluid after birth. It is common in neonates born via C-section. Also occurs in smokers, diabetics, SGA, preterm, or precipitous delivery. Assessment-wise, we're going to see that these babies are having a respiratory effort. They're going to be tachypnic. They're going to be breathing at greater than 60. They're going to be grunting, flaring, having retractions. You're going to see some cyanosis. The chest X-ray may reveal some streaking from the lymphatic engorgement of any retained fetal lung fluid. We want to provide nutrition via gavage feedings because when a baby is tachypnic, we typically do not feed them because they are going to, if we nipple these babies, they're likely going to aspirate. They have difficulty, of course, with the oral feedings during that time. And, it's a coordinated effort, suck, swallow, breathe, suck, swallow, breathe. And while we're doing this and we're doing suck, swallow, breathe, if they're breathing a lot faster, then they're likely going to aspirate as they're trying to swallow. So patent ductus arteriosus, assessment findings, we're going to hear a systolic murmur. They're going to be tachycardic, bounding peripheral pulses. They're going to be tachypnic, have increased respiratory effort, crackles, poor feeding, sweating while feeding, and tire very, very easily. It should constrict after birth and close within hours or days, but it's slower in the preterm infant. But a growing premature infant that shows signs of worsening respiratory status, like if they have increased O2 needs and increased vent settings, maybe they're acidotic and hypotensive, then they may be exhibiting signs of a PDA. And they're probably going to show on x-ray that they have cardiac enlargement and pulmonary edema if they're having a large amount of shunting. The good thing about it is sometimes that it can be handled medically, and that's where we're going to start. We're going to do vent support, fluid restriction to decrease the cardiovascular volume overload, diuretics, indomethacin, and ibuprofen. Nursing care is going to be supportive, but a lot of times it can't be. We can't manage it medically, and when it does, and when all else fails, then we'll go in and do a surgical repair on it. Intraventricular hemorrhage, rupture of the thin, fragile capillaries within ventricles, and it leads to increased ICP. It is a very common neurologic injury for preterm infants. Most severe injury in both short and long-term diagnosis, and it's classified usually according to severity. Contributing factors could occur antenatally or postnatally. Care is going to focus on recognition of factors that increase the risk, such as the prematurity or hypoxia. Blood pressure, we want to monitor closely for fluctuations, and we have to also assess for pneumothorax as well. All right, now we've hit neck. Necrotizing enterocolitis. This is something that we want to hit on really good. This is something that has C and NCLEX. It's on the test plans. So with neck, it's an inflammatory disease of the GI mucosa, may be complicated by perforation. Etiology, decreased blood flow and perfusion to intestines due to hypoxia and hypoxemia. 3 factors in development of neck: intestinal ischemia, colonization of pathogenic bacteria, substrate such as formula feeding in the intestinal lumen. It does occur in about 1 to 5% of newborns in NICUs. The exact cause is still unknown. It is often fatal. It occurs in infants whose GI tract suffers vascular compromise. The preterm infant onset may be up to 30 days. Risk factors for neck include asphyxia, RDS, umbilical artery catheterization, exchange transfusion, early enteral feedings, patent ductus arteriosus, congenital heart disease, polycythemia, anemia, shock, and GI infection. It will be diagnosed by radiographic exam. Manifestations really are pretty generalized: abdominal distension and tenderness, increasing or bile-stained residual gastric aspirates, vomiting, bile or blood, grossly bloody stools, erythema of the abdominal wall, and temperature instability. Treatment's going to be rest that GI tract, NG2, parenteral feeding, and systemic antibiotics. Some of these are the signs of neck. Also, they'll have some decreased activity, hypotonia. They're going to have pallor, recurrent apnea, and bradycardia. And you might also see that their O2 sats are tanking. Maybe they're showing signs of respiratory distress, metabolic acidosis. I mean, there's so much. All of these. And here's the thing. Some of the signs and symptoms, because they're just so generalized, they may be misinterpreted for something else with the infant. It is infectious. It must be controlled with antibiotic therapy, and they may end up needing some surgical resection. Apnea of prematurity, they're at risk due to immature regulation of vital functions in the brain. Prolonged apnea greater than 20 seconds can result in some bradycardia. Nursing implications: stimulate respirations with gentle tactile stimulation. If unsuccessful, reposition the neonate and prepare for support with bag and mask if necessary. We also might have to give caffeine or theophylline. It usually does resolve by the 36th week of gestation. Retinopathy of prematurity is complex, multi-causal disorder that affects developing retinal vessels of the preterm infant. Prolonged exposure to high concentrations of O2 can cause that retinal hemorrhage. It'll lead to detachment and loss of vision. It's associated with high arterial O2 sats. Disease process may take up to 5 months. We're going to do careful monitoring of these babies. They're going to get, if you've ever seen a neonate in an ICU, get an eye exam. It'll be something you'll never ever forget. That's one thing I can't handle is eyes, but they do those about once a month, and they may have to do it more depending on what they're seeing at those assessments. Bronchopulmonary dysplasia is a chronic lung disease from lung injury in infants on mechanical ventilation and supplemental O2. It's caused by pulmonary immaturity, surfactant deficiency, lung injury and stretch, barrel trauma, inflammation from O2 exposure, fluid overload, ligation of a PDA, or genetic predisposition. It's higher in infants weighing less than 1,500 grams who required mechanical ventilation for respiratory distress syndrome. Symptoms, they're going to be tachypnic, retract, nasal flaring, increased work of breathing, exercise intolerance, and tachycardia. We do PT on babies, that's why that's in there. Treatment is going to be O2, nutrition, fluid restriction, medication. Prognosis really is going to depend on the degree of the pulmonary dysfunction. Prevention, surfactant, antenatal steroids, minimize lung trauma from the vent, and high O2. But the problem is a lot of these babies have a long-term dependence on O2 therapy. So they're going to be in the first year or a couple of years of life, they're probably going to be at risk for more lung infections, more respiratory infections. Now, the postterm infant, their gestational age is beyond 42 weeks. It's associated with placental insufficiency. The infant may appear emaciated even. Mortality is high related to labor with postterm placenta. Complications would be meconium aspiration syndrome, persistent pulmonary hypertension of the newborn. Placenta is not intended to work really good past that 38-week mark. It begins to calcify. That's why at 40 weeks we're going to deliver. Some babies stop gaining weight once this occurs, and they may become SGA due to lack of nutrients. However, some babies continue to gain weight and become LGA, which may inhibit the mother's ability to deliver vaginally. There's a lot of controversy about delivering the baby early or waiting for nature to take its course. Okay, so when we're talking about the postterm infant, we're looking at, for assessment-wise, they're probably going to be absent vernix, minimal lanugo on them. They're going to have very dry, cracked skin, minimal subcutaneous fat. The skin and the cord could be yellow if they've had meconium staining. They have long fingernails, and they have this alert, wide-eyed look. We still have to monitor these babies very closely because they can become hypoglycemic and hypothermic very, very easily. So we just talked about the postterm infant and the fact that they could have meconium staining. So now let's talk about some meconium aspiration syndrome. Aspiration of meconium into the tracheobronchial tree can happen during the first few breaths. What happens is they get prenatal asphyxia is caused by increased peristalsis and relaxation of the anal sphincter, so then they have passage of meconium. You need the neonatal resuscitation team there at the delivery if we know that there's meconium staining. It occurs in about 10 to 15% of all births, and usually in term and postterm infants. PPHN also called persistent fetal circulation, pulmonary hypertension that results from right to left shunting with a structurally normal heart. They're going to have tachycardia and cyanosis. It progresses to severe respiratory compromise within minutes to hours. If it continues, baby, the right to left shunting is normal, though. Let me go back. The right to left shunting is normal in fetal circulation, but not after the baby is born, okay? If it continues, the baby will show signs of some respiratory compromise where you're going to see some tachycardia and the cyanosis. The foramen ovale and ductus arteriosus should close in response to biochemical processes, pressure changes in the heart, and dilation of the pulmonary vessels. If there's any process that interferes with this, it'll cause the baby to have PPHN. We can treat with high-frequency ventilation or other assisted ventilation methods like nitrous oxide. SGA or IUGR babies, small for gestational age or intrauterine growth restriction, IUGR is sometimes used as a more descriptive term for the SGA infant. AGA would be inappropriate for gestational age infant, and that birth weight would be anywhere between the 10th and the 90th percentile. So an IUGR or SGA baby has a birth weight that has fallen below the 10th percentile. There's two different types. You have symmetric and you have asymmetric. In symmetric IUGR, the weight, length, and head circumference are all affected. But asymmetric, the head circumference remains within normal limits. The birth weight falls below the 10th percentile, though. Both are at high risk. They have perimortality rate at 5 to 20 times higher than normal term babies. There are some causative factors in it for symmetric. Could be infections, teratogens, or chromosomal abnormalities. If it's in the second or third trimester, we're looking at the asymmetric. So there's maybe some placental insufficiency that maybe it could be related to smoking, hypertension, substance abuse, or malnutrition. What we're going to see is these babies, their skin is loose and dry. They have little fat or muscle mass. They have only a little scalp hair, a very weak cry. The problems that affect these infants, they're going to have problems with gas exchange. You got to prevent cold stress in them, hypoglycemia, and of course the temperature instability. So we might have to make sure these babies are assess their temperature a little bit more frequently if they are within our term nursery, and make sure that they're maintaining that normal temp that we would expect with our new. LGA infants their weight is 4,000 grams or more at birth. They're above the 90th percentile. So they're also at great risk for morbidity, more than the SGA infant. They have a very high incidence of birth injuries, asphyxia, and congenital anomalies such as heart defects. Need careful monitoring in labor and need to be prepared for C-section if mama cannot deliver this big baby. We have to monitor for hypoglycemia after birth. I don't know how many times I stress that with LGA babies. The babies are at risk for birth injuries like shoulder dystocia. Let's see, mom might have some ineffective contractions because she has an overextended uterus. They're at risk not only for that, but fractures such as a clavicle fracture, the paralysis, the facial paralysis I talked to you about earlier on in the lecture. They're at risk for that as well. Hypoglycemia, all infants are at risk for it. The SGA is because they do not have fetal stores. Physiologic stress can result in decreased glycogen supply and inadequate glucogenesis. The preterm risk, inadequate intake and increased metabolic demand. We're going to see babies with tremors, jitters, irritability, poor feeding, apnea, tachypnea, grunting, and poor tone. With the hyperglycemic baby, the blood glucose level is greater than 125 in whole blood, or 145 to 150 in the plasma. It is seen in low birth weight infants, primarily related to the parenteral nutrition. Can be as bad as hypoglycemia because fluid shifts result in cellular dehydration and intraventricular hemorrhage. Infants of diabetic mothers, maternal insulin can't cross the placenta, okay, but glucose can. And then we get a rise in the fetal glucose. The fetal pancreas responds to it with increased insulin production, then metabolizes the glucose and acts as a growth hormone. So maintaining your mom's blood glucose level within that tight range of 100 to 120 can eliminate some of the problems for these infants. The problems that they're at risk for are congenital anomalies. I've talked to you about that, cardiac and cardiomyopathy, macrosomia, birth trauma, perinatal asphyxia, respiratory distress syndrome, hypoglycemia, hypocalcemia, hypomagnesemia. I butchered the name. Hyperbilirubinemia and polycythemia. What we're going to find is these babies have, they're large for gestational age. They might suffer some birth trauma. They're going to be that hypoglycemic. Then we're going to start seeing them exhibit some respiratory distress syndrome because increased insulin needs reduce that surfactant production. So you're also going to see enlarged organs such as with the heart, liver, and congenital anomalies occur in about 10 to 15% of babies born to diabetic mothers. These can be caused by fluctuations in blood glucose levels and episodes of ketoacidosis early in pregnancy. When anomalies are known, of course, labor and delivery nurses' responsibility is to be sure to have all staff there necessary and equipment in the delivery room when the baby actually delivers. If the facility has an NICU, the baby will be taken there immediately after birth. If not, we'll get them stabilized and transported to a regional facility. Because of the increased insulin needs, you're going to have a baby that's going to be born very, very large. With the incidence is high with babies of insulin-dependent moms, despite all improvements that we've made in control of glucose levels. Even the placenta and umbilical cord are larger than average in these babies. The brain is the only organ that doesn't get enlarged. Even though these babies are LGA, many of them are not physiologically mature. I kind of have talked a little bit along the way about transport of mom or baby to a facility that can take care of their needs much better. Wheel transport in ICU at Little Rock will transport babies out to Arkansas Children's Hospital if they have birth anomalies that we are not prepared to take care of within the NICU here. If not, I mean, we hope that mom and babe can stay together, but it doesn't always happen. So it can be a big stressor on both the parents. Best thing to do, I'm just going to kind of run through this. Give them a location of the unit. Maybe dad has to go, mom stays in the hospital while she recovers. You want to get them the names of those that are involved in the care of the infant and information about the unit and lodging close by the hospital if their baby's being transported out. Okay, babies are usually discharged from the regional facility. It says that they can be transferred back, but typically we don't. They get discharged from wherever they were admitted to. If they were admitted to Children's, they're going to be discharged from Children's. If they're admitted to us, they're going to be discharged from us. We'll get specific discharge instructions. One thing that is important to know, and this may be important for you to know for testing purposes along the way, and even on your standardized test, is that we're going to do the corrected age and prematurity at discharge. If a preterm baby was born at preterm at 28 plus 5, and they do not go home until they are close to their gestational age, which is usually when they do, we'll tell moms they can expect that their baby is likely going to discharge home when it's close to what their due date was. So if they were admitted to the NICU at 28 plus 5, that's when mom delivered, and they go home at 38 plus 6, then that's the corrected gestational age that we'll use, and that's how we'll do it. And that's usually done until about the time that they, they start becoming around a year old. We stop doing those adjustments, but up until then, we usually keep those adjustments going. And even past that, it's going to depend on micropreemie or not micropreemie. Like I have a set of triplets at our church right now that their birth date was actually in October. They turned a year old. That was their birth year, but gestational age, it wasn't until January when they would have been at a year old gestationally. So I mean that I'm just trying to explain how we look at it and how we deal with these babies once they discharge. And the reason being has to do with when they're going to pediatrician's office. We're not going to treat them like a normal 2-month-old. We're going to know that gestationally they are at this age right here. So neonatal infections and sepsis. Presence of microorganisms or their toxins in the blood or other tissue. One of the most significant causes of morbidity and mortality among neonates. Neonatal neutrophils have decreased functional capabilities. Remember that maternal IgM does not cross the placenta. Amount of infant IgG is directly proportional to gestational age. Other immunoglobulins need time to mature after birth, so preterm infants, their white blood cells can't fight infection efficiently, and they have an immature GI mucosal barrier, so they're more susceptible to infections. So when we're talking about neonatal infections, there's early onset or congenital that it'll manifest within 24 to 48 hours. Late onset will manifest at 7 to 30 days of age. With early onset, it progresses more rapidly and it has a 50% mortality rate. It's associated with preterm labor, prolonged rupture of membranes, maternal fever, and chorioamnitis. Now, if it's a late onset, bacteria, we're looking at it's entered through like the umbilical stump, the skin, mucous membranes, respiratory, nervous, urinary, GI systems. We need to always know what the prenatal history is and monitor mom very closely once the membrane's ruptured. Prolonged labors with use of internal monitoring and mini vaginal exams may set that baby up for an acquired infection. We got to be aware of our actions. We don't want to jeopardize either one of them, actually. We always need to use good technique when caring for our patients. Some of the risk factors for neonatal sepsis: low socioeconomic status, poor prenatal care, poor nutrition, and substance abuse. Intrapartally, there might be a risk because of premature rupture of membranes, prolonged labor, or membranes ruptured greater than 18 hours, maternal fever, chorioamnitis, premature labor, and maternal UTIs. Now, in the neonatal period, it can be because they're a twin or a multiple gestation that puts them at risk. Males, birth asphyxia, meconium aspiration, congenital anomalies of the skin or mucous membranes, absence of the spleen, galactosemia, low birth weight or prematurity, and malnourishment or prolonged hospitalization will also put them at risk. Remember back a few slides we talked about neck. So it has a lot of vague symptoms. We're going to assess some of those vague symptoms with neonatal infections as well. Temperature instability or hypothermia. Is it an instability? Are they really hypothermic, or is the isolate temperature need to be adjusted? Feeding intolerance, abdominal distension, they just don't look right. Maybe they're lethargic and they have some pallor. Progressive respiratory distress, hyperbilirubinemia, tachycardia followed by apnea, and bradycardia. What are we going to do? We have to get blood cultures. We need to assess blood, urine, CSF, administer antibiotics, and we have to continually assess these babies. they're at high risk, and we have to make sure that we are prepared to intervene appropriately. Hand washing, standard precautions, careful cleaning of contaminated equipment, frequent replacement of used equipment, changing IV and NG tubing per protocol, cleaning resuscitation and ventilation equipment. Another way that babies can become infected, nurses that take care of them with artificial and long natural fingernails. Those have been associated with some serious neonatal infections and morbidity. Now, there's a panel that we will draw on babies. It's called a torch panel. It may be ordered to determine if they have any of the perinatal infections that infants can acquire. And you can see here, T is for toxoplasmosis, O, other, so we're looking at gonorrhea, syphilis, varicella zoster, Hep B virus, parvovirus B19, and HIV. Rubella, cytomegalovirus, and herpes simplex virus. So toxoplasmosis, we're going to talk about each and every one of these just a little bit. It's a multi-system disease. Humans can become infected after disposing of cat litter, handling or ingesting raw meat from cattle or sheep, eating unwashed or unpeeled fruits and veggies. First trimester exposure is the most serious for the fetus. 10 to 15% of infected infants die. 85% have severe psychomotor problems or cognitive impairment by age 2 to 4 years. 50% have visual problems by age 1. We treat with pyrethrolamine and oral sulfadiazine, as well as folic acid supplement. Gonorrhea may be present with chlamydia infection. Usually if they have gonorrhea, they probably have chlamydia. It's just something you need to know. It kind of goes hand in hand. With the rupture in the membranes, the fetus can be infected through the oral gastric route. They can be infected through the birth canal. It invades the mucosal surfaces, the conjunctiva, rectal mucosa, pharynx. Eye prophylaxis will do. Erythromycin is always done after birth. I already talked to y'all about those meds. Mild infections, so the infant recovers completely with treatment. We probably do a single dose IM or IV ceftriaxone. Occasionally death is noted if the infection overwhelms the infant. Alright, so syphilis. For every 100 women diagnosed with primary or secondary syphilis, 2 to 5 infants will contract congenital syphilis. The fetus is protected from the disease during the first 16 to 18 weeks of gestation, but as the Langerhans layer in the chorion begins to atrophy, then the spirochete will cause death if it's left untreated, and that's usually during the mid-trimester, by the mid-trimester. All neonates infected before 7 months gestation are affected. Only 60% are affected if the infection occurs late in the pregnancy. Treatment, we're going to take care of mom, hopefully before 18 weeks, so we can maintain that healthy, viable pregnancy. Severely affected infants have untreated mothers, and a newborn may be edematous and anemic. They'll have an enlarged liver and spleen. Neonatally, the infant may be present with poor feeding, slight hyperthermia, and snuffles. The snuffles is because they're going to have this copious, clear, serosanguinous mucus discharge from their nose. All right, so now let's have a little nursing alert here for you. The infant with congenital syphilis may be entirely asymptomatic. So what does that mean for you? You might not know until after discharge from the hospital, if you ever know. It is imperative that caregivers use standard precaution with all newborns. Hep B, parvovirus 19, and HIV. Varicella or the chickenpox virus will cross the placenta and infect the infant in the first trimester. Doesn't happen often, but when it does, it can cause some limb atrophy, neurologic abnormalities, and IUGR. If it occurs in the last few days of pregnancy, 20% of the infants will be born with clinical varicella. Infants who have severe Hep B have a 75% mortality rate. Parvovirus B19, fifth disease in older children. They're at risk for pericardial, pleural, and peritoneal effusions. HIV can be prevented in the newborn by treating the mother during the pregnancy. And they're probably going to end up with a C-section delivery also because this greatly decreases the amount of transmission of the disease. The treatment regimen is going to be during the antepartum, intrapartum, and we'll do neonatal treatment. It is rare for an infant to be born with symptoms of HIV, but all infants born to seropositive mothers will be presumed to, we're going to presume them to be positive until we know otherwise. Okay, so rubella, also known as German measles, 3-day measles. Congenital anomalies with this depend upon time of exposure gestationally. Most severe if contracted during the first trimester, but one of the biggest anomalies with it is hearing loss. We have to isolate them after birth because they're contagious until their mucus and urine are free of the virus. Cytomegalovirus at risk for miscarriage, stillbirth, or congenital illness. Assessment, we're going to find they have hepatosplenomegaly, lymphedema, IUGR, jaundice, hepatitis, thrombocytopenia purpurea with petechia, and blueberry muffin lesion. Herpes simplex virus, the transmission mode, transplacental infection, ascending infection by way of the birth canal, direct contamination during the passage through an infected birth canal, so direct transmission from the infected personnel or family. Most are affected through the vaginal birth, so C-section is the preferred method of delivery. Standard precautions with these infants. I will say I've cared for moms over the years that the physicians have allowed for a vaginal delivery because they've said, we see no active lesions. Well, I'd really like to know how you validate that they have no active lesions, because we don't see what all's going on. We don't know what's all there. And so I think if I were diagnosed with it, I would want to deliver my baby via C-section to reduce the risk of exposure. Bacterial infections we're looking at, Group B streptococcus, fungal infections. Now, according to your text, historically GBS was one of the most common causes of neonatal sepsis and meningitis in the U.S. However, GBS, considered normal vaginal flora, is found in 10 to 30% of healthy pregnant women. That's why we make sure that we test our moms, and we want to do so. They're screened at 35 to 37 weeks so that we can give them antibiotics during labor. We don't want these babies born and birthed through the canal without having had those antibiotics. Symptoms do mimic RDS and can be present within 24 hours. It has a high mortality rate. These babies are sick if they get bacterial infection from Group B streptococcus. Ugh, tripped over that, sorry. Congenitally acquired TB is almost always fatal. Chlamydia, they'll have conjunctivitis for 5 days to 2 weeks post-delivery. We're going to treat with erythromycin orally. Diaper dermatitis, it can manifest as moist raised red rash with small white or yellow pebbly pustules. It's going to be in their inguinal folds, perineal area, and lower portion of the abdomen. We're going to do topical nystatin. And of course, oral yeast or thrush, they'll have white plaques on their oral mucosa. Patches can't be removed. Typically don't seem to feel pain from it, but they may refuse a breast or a bottle. If they're breastfed, we're going to have to treat mom and substance abuse. Recreational drug use, cocaine or marijuana is the most often used. Tobacco smoking, and alcohol, two legal substances that are used as well. Approximately 50% of mothers' dose of medication or drugs go straight to the baby. It's important to know that mothers who abuse one substance will likely abuse another, so it compounds the problems that an infant is likely to experience. And we're also going to talk here in a few slides about NAS, neonatal abstinence syndrome. The types of drugs that you can see typically used: amphetamines, heroin, nicotine, PCP. Those are all drugs that can cause some significant physiologic and behavioral problems. These are irritable babies. I mean, they really are. Fetal alcohol syndrome, 0.2 to 1.5 per 1,000 live births are diagnosed with FAS. It is a leading cause of cognitive impairment. Alcohol interferes with normal fetal development, so effects on the brain are permanent. The incidence is on the rise in the U.S. You would think that it would not be, but because it's an entirely preventable disease, cognitive disease. We don't know the exact amount that it takes to cause FAS, so we just don't want to encourage moms to drink it at all. Just stay off the alcohol while you're pregnant. It could be 1, it could be 20. It could be that she has to drink the whole time in order for it to affect the fetus. But either way, we want to encourage our moms not to drink. What are you going to assess in these babies? They're going to be SGA, irritable, hyperactive, poor feeding and vomiting. Their facial features. You actually have a picture of one in your book. I took it out of the slide for, I guess for size purposes. I'm really sorry about that. But you'll see that how their epicanthal folds are. You need to look in your book and look at that picture. They'll have maxillary hypoplasia and have this long, thin upper lip. With these babies, we want to make sure we reduce their environmental stimuli, swaddle to increase the feeling of security, administer sedatives to decrease the side effects of withdrawal, and maintain nutrition and hydration. Neonatal abstinence syndrome. This is another thing that I want you to know about. We talked a lot about NEC back earlier on in this lecture. Now we're going to talk about neonatal abstinence syndrome. These two things here, you're going to see them quite often on your standardized exams if they're going to have any high-risk questions on there. These moms are at risk for a spontaneous abortion and preterm labor and stillbirth. So what happens is they have repeated intrauterine absorption of drugs from the maternal bloodstream that causes some fetal drug dependency, thus neonatal dependency. Degree of drug withdrawal depends on the type and duration of addiction and maternal drug levels at delivery. Smoking causes low birth weight infants, preterm births, and an increase in the number of miscarriages. Infants receive higher concentrations of substances in tobacco than the mother, and it's also excreted in the breast milk. The assessment findings are going to be hyperactive, jittery, shrill, persistent cry, frequent yawning, sneezing, nasal stuffiness, respiratory distress, feeding difficulties, and developmental delays. You're going to intervene by decreasing their environmental stimuli. We want to make sure we obtain meconium or urine for drug screen. Phenobarb, Valium, or Thorazine may be administered to decrease that hyperirritability. A pacifier for non-nutritive sucking, and swaddle and hold the infant tightly. You might have to do some rhythmic rocking as well to just keep them calm and keep them happy and satisfied. With heroin, you're going to see a low birth weight baby. They're going to be irritable, tachypnic, feeding difficulties, vomiting, high-pitched cry, and seizures. You're going to see a lot of these that overlap one another. Methadone is going to resemble the heroin withdrawal. They're going to have tremors. They're going to have state lability, hypertonicity, hypersensitivity, mottling, and nasal stuffiness. There's other substances that they can have withdrawal from, methamphetamines, phenobarb, and even caffeine. But an important thing for you to note is that the use of naloxone or Narcan is contraindicated in infants born to narcotic addicts because it may actually exacerbate their neonatal abstinence syndrome, and then they will start having seizures. Patient teaching. Infants experiencing withdrawal, we want side-lying position with spine and legs flexed, hands in midline with arms at the side. Carry the infant in a flexed position. Only introduce one stimulus at a time during quiet and alert states. Watch for signs of the distressed infant if they have gaze aversion, yawning, sneezing, hiccups, they're arching, mottled color. Swaddle the infant, rock in a slow, rhythmic fashion. Place the infant in a sitting position with chin tucked down for feeding. Smoking will likely cause the baby to be a low birth weight baby. They can also have miscarriage and preterm birth. Infants born to these moms have been found to exhibit deficits in growth, intellectual and emotional development problems, poor auditory responsiveness, increased fine motor tremors, hypertonicity, and decreased verbal comprehension. Neonates do experience withdrawal syndrome. There are also problems associated from smoking. They could have heart defects, septal defects, cleft lip and palate, and increased childhood otitis media. So we're going to talk about hemolytic disorders, and I think you can imagine that hemolytic disorders are probably one of those things that you will be tested over throughout the spectrum within theory and as well as HESI and state board. It occurs when blood groups of mother and a newborn are different, so that's why it's such a big deal. They have RH incompatibility or ABO incompatibility, or they could have some other hemolytic disorder. It occurs if the maternal antibodies are present naturally. It occurs when the antibodies are present naturally or form a response to an antigen from fetal blood crossing the placenta and entering maternal circulation. It could result in just pathologic newborn jaundice, but it can be something more severe. With RH incompatibility, isoimmunization, only RH positive offspring of RH negative mother is at risk. If the fetus is RH positive and mother is negative, the mother forms antibodies against the fetal blood cells. Fetal red blood cells enter maternal bloodstream and cause maternal antibody formation, and so you get maternal sensitization. In subsequent pregnancies with an RH positive fetus, antibodies will cross the placenta, enter fetal bloodstream, and attack fetal red blood cells, causing hemolysis and anemia. It can occur during pregnancy, birth, induced abortion, miscarriage, or at an amniocentesis. And it usually occurs only in the first pregnancy. What do we do if they have RH incompatibility? Well, RhoGAM. That's what we do to prevent the development of antibodies. It does begin with the first pregnancy, but it is the subsequent pregnancies that develop the problems. So infants born of mothers who have not received RhoGAM will develop hemolytic disease of the newborn. Severe RH incompatibility can cause marked fetal hemolytic anemia, leading to erythroblastosis fetalis. And we'll do direct Coombs. You probably see it on their crib. If you've seen any of those, we'll write direct Coombs on there. And we might have to what we'll do is, if they're indirect Coombs, let me back up. Indirect Coombs, positive if maternal antibodies present in maternal blood. Indirect is positive if maternal antibodies are present in the fetal blood. And what I was trying to say is that if we find out that they're direct Coombs and they're going to need something beyond a phototherapy, such as exchange transfusion, then we're going to likely use cord blood. ABO incompatibility is more common than RH. Less severe problems, though. What they're going to find is the cord bilirubin level is usually less than 4. Treatment, phototherapy, occasionally may need exchange transfusion cells. Congenital anomalies occur in 2 to 3% of all live births. It's a number higher in miscarriages. Most common are congenital heart disease, abdominal wall defects, imperforate anus, neural tube defects, cleft lip or palate, clubfoot, and developmental dysplasia of the hip. Encephalocele or anencephaly. These are some central nervous system anomalies. Spina bifida is the most common defect of the CNS. It's a failure of the neural tube to close at some point. Hydrocephalus and microcephaly. If it's an encephalocele, the brain herniates and the meninges through a skull defect, and it's usually at the base of the neck. Anencephaly is the absence of both cerebral hemispheres, and they're not compatible with life. Hydrocephalus, they're going to have enlarged ventricles, where we talk about looking at the fontanelles of a newborn and we want to see them flat, we don't want to see them depressed, and we don't want to see them bulging. It can cause microcephaly, causes restricted brain growth, cognitive impairment, and may require supportive nursing and observation, but no treatment. Spina bifida. I will say right now that y'all have heard a little bit about that, the nursing intervention for, we have a baby that's born with meningocele. The most important thing that we can do is protect the sac from injury and rupture. The external sac it protrudes through the defective vertebral column, so it contains meninges and CSF. Meningocele is similar, except it also contains nerves, so the infant will have sensory and motor defects. Cardiovascular system anomalies. We're thinking about PDA, ASD, and VSD, tetralogy of Fallot, often associated with some other congenital anomalies. It's the second major cause of death within the first year of life, and prematurity is the first cause. Sometimes we just don't know why it happens. Infants will have central cyanosis despite 100% O2. They may be restless, lethargic. They're going to have some respiratory symptoms. Respiratory system anomalies, choanal atresia, and congenital diaphragmatic hernia. My dad had a congenital diaphragmatic hernia that actually I wondered how he did when he was a child, because what you see is that these babies have difficulty initiating respirations, gasping, flaring, grunting, barrel chest, and asymmetric chest expansion. But somehow he ended up surviving without any correction with this until he was almost 60 years old. And that's when he actually got it repaired. Choanal atresia, bony or membranous septum between the nose and the pharynx. They have difficulty breathing. Cleft lip and cleft palate. Probably one of the common ones that we see. Cleft lip, the newborn can't maintain a seal around the nipple. Cleft palate, the newborn is unable to maintain a vacuum to maintain suction during feeding. They are at increased risk of aspiration. Breastfeeding is preferred with palate. You have to know that they may result in them having milk come out of their nose. Sometimes it's difficult for parents to deal with these anomalies because it's very evident, it's visible. It can be a genetic component or it can be environmental, such as maternal infection, tobacco exposure, radiation exposure, alcohol, and certain medications. Parents need support. Correction is normally done with the lip at about 6 to 12 weeks. Weight gain is established and they have to be free of infection. Palate, 12 to 18 months, and that allows for all the palatal changes that take place with normal growth in the first 12 to 18 months of life. It is closed, though, before the child develops any faulty speech habits. An esophageal atresia, a tracheal esophageal fistula, omphalocele, gastroschisis, anorectal malformations, and intestinal obstruction. These are all GI malformations that can develop as well. And fistula, that's an unnatural connection with the trachea. Esophageal atresia, esophagus ends before it reaches the stomach. Omphalocele is different from gastroschisis, but omphalocele is a herniation of some of the abdominal organs covered by a membrane that holds them intact. But gastroschisis is also a herniation of abdominal contents, but they are loose and they spill onto the baby's abdomen. Both of these should be covered with sterile saline, warmed to prevent heat loss and electrolyte imbalances. With the club foot, you have one, two, three, four different types. I'm not going to read through these. I will just expect that you will understand what each one is. More musculosystem anomalies, polydactyly. That, if you've ever seen it, it's kind of creepy. Sometimes my students have seen them in NSU and come back and said, "Oh my God, you're so right." But sometimes they get extra digits on their hands and feet. It is hereditary. If no bone is present, then they're going to tie it off that extra digit with a suture, and then it'll just. GU system anomalies, hypo or epispadias. It is the most common penile anomaly, 1 in 250 to 300 male births. Hypospadias is an abnormally located meatus. Epispadias, widening of the structures. With hypospadias, there's different degrees of it. You can have a proximal hypospadias, and you can. And let me just tell you that the degree of that one is you're looking at at the urethral opening that's right there at the base of the penis, right as it meets the scrotal sac, and that's the most severe one. That requires quite a bit of surgery to repair it, but it can be repaired, and these young men lead happily normal, healthy lives. Extrophy of the bladder. Bladder is visible in the suprapubic area. It'll be a red mass with multiple folds, urine draining onto the skin. Ambiguous genitalia. Um, this is another one that we sometimes see, and I guess we see it enough now that there is an ambiguous genitalia clinic at Children's Hospital. And then we could also have babies born with a teratoma, and that means that they'll have an embryonic tumor that contains solid, cystic, or is a mixed mass. It's benign though, and can be removed. All right, ladies and gentlemen, that is the end of your high-risk infant lecture. I will see you in the classroom.